Hello and welcome to the Medicoryx platform. So today we will be talking about obstetric and perinatal outcome in the women with endometriosis. This is a very beautiful talk article which was released in October 2022. So we all know about the endometriosis, right? So endometriosis is the growth of endometrial tissue outside the uterus, and it almost affects around 10% of the women, and 30% of those affected will present with subfertility. Endometriosis has a negative impact on both assisted and natural conception. Mechanism proposed to account for fertility impairment include altered folliculogenesis, which results in ovulatory dysfunction, and poor oocyte quality, as well as luteal phase defects, reduced fertilization, and abnormal embryogenesis. So, what it will cause to the obstetric population? So, first of all, we are going to, find out what is the pathophysiology of adverse obstetrical outcome. The pathophysiological mechanisms by which endometriosis is thought to affect obstetrical outcome is secretory phase endometrial changes, which leads to endometrial proliferation, glycosylation, and progesterone resistance. Secondly, altered junctional zone functionality. Third, uterine hypercontractility, genotoxicity, and chronic inflammation. So by this way, you can just think of that, all these changes in endometrium will lead to somewhat adverse obstetrical outcome. So let's take all these changes one by one. Number one, altered endometrial proliferation. The endometrial thickness typically increases up to 10 millimeter during the proliferative phase. And endometrial thickness is reduced in women with endometriosis. Important concept, which results in an increased risk of implantation failure. So this could be one of the major reasons why there is a reduced fertility potential in endometriosis women. Altered glycosylation means that endometrial receptivity primarily will depend on the presence of surface glycoproteins within the glycocalyx of endometrial cell. So there is going to be an alteration in this glycosylation of surface protein, which will affect blastocyst interaction and reduction in the likelihood of implantation. Fair enough. That also makes sense, right? Third, and another important cause could be progesterone resistance. Progesterone is implicated in halting estrogen driven endometrial proliferation, which recruits the specialized immune cell to support embryonic implantation and preparation of the endometrium for implantation. What we call it as decidualization, right? Two isoforms of the progesterone receptors, PRA and PRB. PR means progesterone, which are located on stromal cells, mediate the effects of progesterone by causing secretion of paracrine factors and upgrading the enzyme 17-beta hydroxy steroid dehydrogenase type 2. So, what does this enzyme do? This enzyme metabolizes estrogen to the weak estrogenic esterone. So, we all know that estrogen E2 is the high potence, and then estrone is going to be the less potent one. There is going to be down regulation of 17 beta hydroxysteroid 2 and decreased expression of the PRB in stromal cells. What it will cause altogether? It will cause a progesterone resistant state. And in turn, what it will cause? It will cause impaired transformation of the stromal cells into specialized decidual cells, which will result in impaired implantation. Fair enough, isn't it? Then, fourth cause could be genotoxicity, means there is going to be an imbalance between reactive oxygen species and antioxidants. And we all know what are antioxidants like superoxide dismutase, catalase, glutathione peroxidase, and vitamin E and vitamin C. So the connection between endometriosis and increased, the ROS production is well established. So what it will cause altogether? It will also cause, the higher miscarriage rate in the nulliparous woman, because what it will do, it will cause genotoxic mechanism in the developing oocytes. Makes sense, right? Then comes altered junctional zone and defective implantation. So the subendothelial myometrium, which also termed as junctional zone, is a radiologically identified zone that is architecturally and functionally distinct from the outer myometrium. The posterior junctional zone appears thickened on 3D ultrasound and MRI in cases of adenomyosis, which may itself be related to abnormal basal invasion of the myometrium by this layer. So the thickness of this layer has been associated with the failure of implantation, because we all know that at least we need up to 5 to 7 of the endometrium thickness for the implantation while we talk about the IVF cases, right? So this could be one of the reason. Then the uterine junctional zone, which becomes the primary site of the placental bed, which is characterized during pregnancy by the remodeling of the spiral arteries into large uteroplacental vessels. So junctional zone disorders, together with the local endometrial pro-inflammatory state associated with endometriosis, will influence decidua or trophoblast interaction, contributing to the various placental disorders. So I think with all these things, we can fairly think of that why there is reduced fertility potential in the woman with endometriosis, right? Then another important cause, inflammation. So what exactly is inflammation and how does it influence? So many studies have demonstrated high levels of inflammatory mediators such as cytokines, interleukin 6, 8, and prostaglandins in the peritoneal fluid of the woman with endometriosis. Furthermore, androgens are aromatized to estrogen by estrogen synthetase. This enzyme is absent in the normal endometrium, but it is abundant in the endometriosis. I think basic concept of the endometriosis. All right. So now altogether we can summarize that what exactly is the pathophysiology and what are the adverse obstetrical outcome. So from here, one or two questions can come in exam. So we can simply think of number one, implantation, then defective placentation, then vessel wall fragility in spontaneous rupture of the vessels. So what exactly is the mechanism? Secretory phase, endometrial changes, altered endometrial proliferation, glycosylation, PRB isoform decrease, 17 beta hydroxy steroid synthase 2 decreased, altered junctional zone, genotoxicity, inflammation, and altered junctional zone and vasculature and remodeling. So altogether, if there is going to be defective implantation, what it will cause? Placenta previa, miscarriage, and recurrent pregnancy loss. If there is any pathology in placenta, what it will cause? Small for gestational age, preeclampsia, and preterm birth. If there is any kind of vessel wall fragility, the endometriotic decidulization implant involution surrounding the distended vessels because of the progesterone resistance. What it will cause? Spontaneous hemoperitoneum in pregnancy. We will talk about it in the upcoming slide. Okay, so I hope it is making sense that how endometriosis is going to affect pregnancy and it will lead to adverse pregnancy outcomes. Okay, so now we will take all these pregnancy outcome one by one. So let's check. Preeclampsia and gestational hypertension. The overall association is not definitively established, but yeah, it can be associated. Placenta previa, yes, important exam question as well as important clinical concept as well. That endometriosis is associated with an increased risk of placenta previa. Treatment with ART by itself is associated with increased risk of placenta previa. And data suggests that even among women who have conceived through ART, the risk is further increased in women with endometriosis. Important clinical concept as well as theoretical for exam. Metabolic complications, it can lead to increased risk of GDM and cholestasis of pregnancy. High risk of GDM in spontaneous conception than those achieved through in IVF with endometriosis. Fetal and neonatal outcome, that in endometriosis, it's also more likely to have preterm premature rupture of membranes, preterm birth, small for gestational age fetuses below the 10th percentile. admission to the neonatal intensive care unit, stillbirth, and neonatal death. Then this was, I was talking about spontaneous hemorrhage in pregnancy. Very important, right? So this is one of the exam question as well. Spontaneous hemoperitoneum in pregnancy is characterized by unprovoked intraperitoneal bleeding with an incidence rate of 1 in 10,000 pregnancies. Endometriosis is associated with 19% to 55.9% of the cases, means 20 to 60% if we round off, right? So, what is the pathophysiology of this peritoneum? The spontaneous hemoperitoneum in pregnancy, which is SHIP, right? Number one, endometriotic decidulized implant invasion, involution of the decidulized, the progesterone mediated component, endometriotic implants, uterine rupture, and chronic inflammation. So, all these things can be the reason for SHIP, which is SHIP. Now, implication of endometriosis for care during pregnancy. For example, if at all woman becomes pregnant, so what will happen to her while she becomes pregnant and pregnancy outcome? Most women with mild diseases are considered as having low risk endometriosis, LRE, and can expect a normal pregnancy and labor. However, the high risk endometriosis, which is HRE, require additional antenatal and intrapartum specialist care. This group includes women with adenomyosis, conception by assisted reproduction, or those surgically treated for peritoneal and deep inflammatory endometriosis, which is rectovaginal nodules. Women with HRE should receive prenatal counseling and can be considered high risk in pregnancy and at the time of delivery as well. In preconception counseling with HRE, who presents with long standing infertility issues and are desperate to achieve a successful pregnancy. So we need to counsel them properly. We need to tell them that you have to agree that their family unit should be complete before embarking upon definitive surgery of endometriosis. Plus, women should be counseled regarding the following: that women having endometriosis, adenomyosis who conceive spontaneously have an increased risk of miscarriage, PIH, preeclampsia toxemia, small for gestational age fetuses, preterm birth, cesarean section, and neonatal admissions as well. Plus, women with endometriosis conceiving with ART have 38% increased risk of preterm birth, 18% high risk of preeclampsia, 87% risk of placental abruption, 29% high risk of neonatal unit admission, and 25% high risk of intrauterine death, and a twofold increase in the cesarean section exam question, and over threefold increased risk of placenta previa. Right? Makes sense. So, how are you going to see them in pregnancy? Antenatal care. Women with HRE should be managed within a consultant led high care pregnancy unit. A multidisciplinary approach should be required. Mental health and well being should be considered because women with endometriosis are at high risk or may already be experiencing mental health conditions such as conceived with ART or posterior, the DI. Blood flow within the adenomyotic lesion is abundant. While placental blood flow may be reduced, this may contribute to the increased risk of PIH, preeclampsia, and small for gestational age fetuses in these women. Furthermore, women presenting with diffuse adenomyosis have a significantly high first trimester and mid pregnancy mean uterine artery Doppler and low PAPA. Okay, I think this could be another exam question as well, and it makes sense as well. What is adenomyosis? Endometriosis into myometrium. Okay, so it will lead to, again, the first trimester miscarriage and the mid trimester mean uterine artery Doppler, the high is going to be there, plus low level of PAPA. Although not evaluated in specific population, low dose aspirin may be beneficial in such situation. So what you will do? Serial growth scans. The risk of preterm birth is there. So with adenomyosis is also higher in those as well as with endometriosis, both, right? Because sometimes adenomyosis and endometriosis both are there, right? Like I said earlier, adenomyosis is endometriosis into myometrium. So usually in non-pregnant individuals, it causes chronic pelvic pain, right? So it can be exacerbated during pregnancy because of adhesions, bowel dysfunction, complication of endometriomas, and pressure from the enlarging uterus. Degeneration of adenomyomas, although rare, can be difficult to distinguish from chorioamnionitis, adenomyosis abscess formation, or acute appendicitis. So, whenever a woman will present with fever, abdominal pain, and raised inflammatory markers, we will be thinking of all these differentials, right? Then, endometriomas can increase up to 20 centimeter during pregnancy. So, we can just imagine that if they increase in up to such size, torsion can occur, cyst rupture can occur, and rarely infected endometrioma can present with peritonitis, which may require surgery as well. So what we will do? We will do the same approach. You know, we will do first of all ultrasound scan. Okay, so it is going to be a preferred imaging modality during pregnancy. MRI without gadolinium contrast, right? Laparoscopy is the preferred operative method prior to 23 weeks of gestation, with laparoscopy being undertaken up to 34 weeks of gestation. Urethral involvement in endometriosis can be found in 9 to 23% of cases, most often associated with ovarian endometriomas and deep infiltrating endometriotic implants. Only 9 to 16% of these cases have urinary symptoms, but rarely can have significant association, including ureteric stenosis, hydroureter, hydronephrosis, and renal damage. I think 9 to 23% is pretty high percentage. So this is again same, right? So the summary of the same what we have read so far, that if endometriosis in pregnancy comes, so we will first of all identify them, either low risk endometriosis or high risk endometriosis, right? If it is high risk endometriosis, first of all, they will be counseled for fertility potential. They will be sent to IVF, the clinics or fertility specialist. They will be counseled for ART, IVF ICSI, or surgically treated severe peritoneal diseases. If there is, the rectovaginal nodules, deep endometriosis, deep infiltrating endometriosis, DIE, bowel bladder endometriomas, so those should be treated as well. Then we will offer them MDT care. We will offer them good preconception counseling, good antenatal care, okay, intrapartum care. Intrapartum care is going to, number one, secure IV access and full blood count and group and save in established labor, right? Then continuous CTG monitoring in labor, increased risk of failed induction of labor and obstructed labor, early recourse to cesarean section, senior obstetrical present in the cesarean section in previously extensive surgically treated cases of endometriosis. Naturally, there can be increased risk of adhesions. Postpartum, risk of PPH and manual removal of placenta, risk of neonatal unit admission post delivery, risk of postnatal torsion with large ovarian endometriomas. And we all know postpartum ovarian torsion is quite common. Intrapartum care, just we have discussed. Okay. And endometriosis is also associated with increased risk of breech presentation, right? This could be because of endometrioma presence. This could be because of, the injuries. Okay. This could be because of the adhesions. The risk of cesarean section, however, is increased, right? Then there is also increased risk of cesarean delivery in women with deep infiltrated endometriosis of the anterior and the posterior compartment, regardless of previous surgeries. So you need to have a full picture prior to disease severity. Then some patients may have undergone endometriosis ablation, peritoneal stripping, or dissection in the close proximity of the major ovarian and uterine vessels. So we need to look at them very carefully because these women may have more complex procedures such as colorectal resection and uterovesical reimplantation. Plus, in rectovaginal lesions, the pelvis may be obliterated. So the change, it can be a very challenging situation. Opportunistic surgical treatment can be considered to remove large ovarian endometriomas at the time of planned elective cesarean section to avoid pain and torsion in the postnatal period. So this is almost a summary of the obstetric outcome from systemic review or the meta-analysis. So There has been, the multiple studies been conducted all around the globe, and then they found out that this was the meta-analysis. However, in almost all studies, preterm birth has been increased, followed by small for gestational age, followed by the this cesarean delivery, PPH, okay, and then malpresentation, neonatal unit, the admission, and stillbirth rate as well in some studies. So we can simply say that yes, preterm birth less than 37 weeks is quite common in the woman with endometriosis, followed by small for gestational age, followed by cesarean delivery. Postpartum, active management of third stage of the labor should be done. It will help reduction in the risk of the postpartum hemorrhage, risk of postpartum anemia, and altogether risk of blood transfusion. Pregnancy creates a pseudo-menopausal state which helps remission of the disease, so patients should be informed that they may experience recurrence of the symptoms in the puerperium. Spontaneous hemorrhage in pregnancy is associated with mild endometriosis that has also been described as late as day 9 postpartum, and therefore unexplained abdominal pain or hypotensive after birth warrants further investigation. So I hope this is somewhat helpful for all of you, that how endometriosis is going to affect the fertility potential and what are going to be the perinatal and obstetrical outcome associated with endometriosis. Thank you so much for listening to me. I will come back with another exciting talk article next week.